So Rick, I went to Alaska and I worked for a couple weeks back in like 2016, 2017, something like that. And it was pretty remote. Like they told me if something happened, it was going to be me and this patient for hours, maybe the whole day until the Coast Guard or a helicopter, whoever could get out there. Let's say something significant happens on one of these lines. Um, what is the patient care time? Like, I know it's all different depending on the situation, but what would an average time be like? Like, if I joined it today and I had something, should I expect worst case scenario to be hanging out with this patient for half the day, a whole day, whatever?
So I'm a member of the Alaska Division of Forestry Fire Medic Program, and we train to be with our patients for up to 72 hours.
Whoa.
I would say
Nice.
wildland fire, my ultimate goal and how I staff my fires and my expectations is to have my patient to the last leg of transportation within an hour. That's what we shoot for. Uh, I've seen I've seen 20-minute extraction times, and then we've got the Duval Creek IWI that happened on the Anvil fire a couple of years ago. That was 3.5 hours to extract a patient, and then they still had another hour and a half drive in the ambulance.
Mm-hmm. And most of the time it is with the ambulance. I mean, depending on the severity of the injury or the illness, whatever. Most times in the
Yeah, and
ambulance.
and that's what when I say extraction, that's getting them off of the fire ground to the last leg of transportation to definitive care, whether we're putting them on ground, air. Um, my primary plan in Alaska is fixed wing because we're outside the rotor bubble for everything.
Uh, and so, Rick, in terms of ALS equipment that a medic might carry, given they may have to hike all of this in, what exactly would they have as part of their kit?
So I'm super big about light and fast, and I like the March mnemonic. And so I'm telling everybody like, hey, this is how you build your kit. And people chuckle at me and I said, here's the thing. I go, all you need to do is keep the red stuff on the inside going round and round and air going in and out. You still have a patient. Everything else we do is fancy. And fancy can come a little bit later.
Amen to that.
So, what does that look like, though, from a kit perspective?
So
And
so
drugs.
yeah, so your goodies to take care of massive hemorrhage, and then obviously airway. Like for me, I only carry 3 ET tubes, the common size tubes and a blade. I'm not looking at sizing people. It may not be ideal, but if I need to do a crash airway, I can do the crash airway. I carry an eye gel for cardiac arrest and those instant type airways that are needed, and NPAs. And then respirations obviously carry a pocket or a tactical BVM for doing that. And then circulation, I carry epi, and so I'll do push dose 1 to 100 push dose epi to maintain MAP to keep organs alive if we've got some hypotension going on, and then stuff for the hypothermia. Keeping your patients alive, keeping those clots that you've managed to build, staying there and maintaining uh, keeping the red stuff on the inside. And then I don't carry oxygen on the line, but I have bulb nebulizers to nebulize my medications. And then I carry a few of the other, some of my cardiac meds, take care of too fast, too slow. And then um, pain management, like pain management. But I'm really big on my pain management is position of comfort and splinting. That means more than most of the narcotics that you can give.
So, you do carry narcotics?
Yes. Yep, they're usually in my cargo pocket with me all the time.
Right. Gotcha.